Hi, ladies and gentlemen. This is Dr. Novoa. We're going to give a few minutes to send out invitations to all the Essure groups throughout the world. There's going to be about 30 invitations sent out. So if you're part of any of the Essure groups and you're following me on my regular page of Novoa or the professional page of drnovoa.com on Facebook, feel free to invite anybody that wants to see, because this is an open forum and public forum. So today what I wanted to do is talk to you about the information for use, which is the manual that can be found on the Bayer website, specifically associated with Essure. Essure.com. I'm not sure whether or not you can access them internationally, but for those in the United States or maybe in the Northern Hemisphere, you can access the information related to Essure by going to Essure.com on the website, on Googling it. You may Google it. And there are information sections on that particular website. Now, there used to be a lot more information, clinical manuals and the such for healthcare providers. It's no longer available, but at least on the first page of that website, Essure.com, you can access this particular PDF file, which is actually one of the first files that was available to doctors who were placing or managing Essure. Now, again, Essure, just like every other medical device, has got to provide an information use to, more specifically, to the doctors that are placing them or doctors that are managing them. But for all implants, for all devices, part of FDA guidelines or mandatory things is to have a information for use related to the particular product. And that's what we're going to be talking about today. Now, why specifically? Hi, everybody. Hi. Sorry I can't read you that closely, but I'm waving back to everybody that's joining us. And this is very important because of the following information. Now, most of you that have followed me have been following me for the past 6 years. I was invited to join the Essure Promise Forum 6 years ago, a wonderful group of ladies and administrators. Sending a shout out to Angie out there, who's been tirelessly working to try to do this. And she is the main reason why Essure was taken off the market. But 6 years ago, I started providing information related, just fundamental information related to Essure. Hey, listen, read the manual. Okay, that's all you really need to do, doctors. Read the manual to understand what you're supposed to be doing and what you're not doing. Or if you've never placed an Essure, read the manual so that you can give some good information, some valid information to your patients. And what we found back then is that even the doctors that were certified by Bayer were screwing up, and they weren't doing what was in the best interest of their patient. They were actually making things worse and hurting their patients. And lo and behold, this thing skyrocketed as far as doctors that weren't even placing Essure were giving wrong information. Maybe or maybe not from the doctors that were placing Essure, they were also giving wrong information. But it skyrocketed to that even in the attempted removal of Essure, women were getting hurt. And women are still getting hurt. Even though Essure is no longer a product that's available, women are still getting hurt because doctors are giving either wrong information, delayed information, or improperly removing the device. Now, doesn't that sound awful? It is awful, because patients that are already been hurt by the device are going to their doctors hoping that they get proper information, and they're not getting proper information. Worse, doctors are dismissing them. They're being arrogant, egotistical, and basically misogynist, and telling patients that, hey, stop reading Google, stop going on Google and getting information that's false information. In reality, it's the doctors that are giving false information. So the goal and the purpose of this particular video, along with all of the other short videos that we're going to be doing, is to pick one particular subject related to, for example, implants in general, and trying to give some real information and real information to scare doctors into doing the right thing, to actually doing what's in the best interest of themselves as well as their patients. Because if you keep making mistakes, doctors, you're going to get sued and you're going to end up with major lawsuits and maybe even reported to your board. So I'm trying to scare doctors into doing the right thing, which I shouldn't have to. But let's face it, sometimes you do have to kick a doctor in his butt to get him to do the right thing. Especially when they're thinking that, hey, this patient doesn't know more than I do about Essure. Well, maybe you do. You probably have if you've actually taken the time to read or follow all of the files that are Essure Problems Forum, or even taken the time to download this. So I'm giving everyone an opportunity to go online and download from the Essure.com website. As soon as you go to that Essure.com website, over on the right-hand side, you're going to see something, a little section that says Information for Use. Double-click on that, and you will find a file that is particularly, I know this is in reverse because but you will see a file that this is the Information for Use file. That this page is 15 pages long. I'm not going to go over 15 pages with you, but I wanted to highlight some particular points related to Essure. And this also applies to the post-tubal ligation sections. Why? Because, ladies that are in the post-tubal ligation forums, Essure is a form of tubal ligation. And therefore, if you have Essure, you're also going to suffer from symptoms of the post-tubal ligation because you have Essure. So it's not just isolated to Felshie clips, Holka clips, a fulguration of the fallopian tubes or femorectomies for the post-tubal ligation syndrome, and especially related to those in the post-tubal ligation syndrome, all of the symptoms may be even enhanced or worse if you have Essure, because it's a foreign body. So I invited all the post-tubal ligation ladies and members in those groups to join us for these videos. Now, who am I? I am Dr. Julio Novoa. I'm out of El Paso, Texas. I have been doing this for 6 years. I am a primary care physician. I am an OBGYN, and I'm also a cosmetic surgeon. So that has allowed me an ability to cross medical specialties, and a lot of times to be able to focus in on one thing and be able to find a connection with another, where a lot of my colleagues don't do that. They're focused in on their specialty and they're referring patients out, and without us working at this as a multidisciplinary approach to fixing the problem, women get stuck and being answered a question by only one specialty that has no idea what they're talking about related to Essure, because Essure affects not only a local problem, but it's an entire systematic or systemic problem for some women. So today's topic is specifically associated with this manual or this section. And again, I hope you've taken the time to go ahead and download this so that you have an opportunity to read what your doctors should have read and should have memorized before they're talking to you. So if you're going to your OBGYN now who's never placed an Essure, that doctor, before they charge you $100 to $300 for their expert opinions, they should have already taken and downloaded this document and read it, because you can't take this off the cuff. Essure is a foreign body that most doctors have never even heard of before. And so why would they be experts in telling you how to manage that device if they've never even heard about it? And most of the time they're not. They're giving you wrong information. They're giving you below the standard of care information. They're hurting you. This is what's happening. Why? Because the vast majority of doctors were following ACOG guidelines, or the American College of Obstetricians and Gynecologists, who didn't even want to take Essure off the market. Remember that. ACOG and Planned Parenthood didn't even want to take Essure off the market. Why? Because they were getting pressured by their fellows, up to all of 50,000 of them. They were actually saying, Bayer should not be telling us what to do. The FDA should not be telling us what to do. We're the experts with this. You're not. You're not experts in it. Far from it. Okay, you're the ones that were hurting patients. These board-certified OBGYNs were the ones that were hurting patients. Okay, so stop taking it like you know what you're doing, because in the end, that's what you were doing. You were hurting patients, and you continue to hurt patients. So I shouldn't even have to do a video like this, but I'm doing it because I'm trying to get the information out. And for all of you that want to continue following us, please, for my professional page, please follow us on Facebook, because I'm going to try to do this on a weekly presentations. drnovoa.com on the forum, the Facebook forums. Please like it or sign on, follow us, and I will try to provide some information either weekly or bi-weekly or bi-monthly. But I'm going to try to do it every week. At least one little section on one particular subject, whether or not it be primary care, OBGYN, or cosmetic surgery. And we have a lot of topics we can talk about, but today this is what I'm going to talk about. So I hope there's enough time that everybody that wants to sign on internationally has had an opportunity to sign on. Are we doing okay? Okay. Everybody's on? Everybody's been invited. We've invited over 30 Essure forum groups to join us today. And I know that internationally that means that some people are up in the middle of the night. But we're going to record this. We're going to also put it on YouTube. And it's going to be under Dr. Novoa. And I'm going to be talking about Dr. Novoa. The title will be Essure and the Information for Use document. Okay? So for those of you who have been following, I want you to just go to page 2 of this particular document. Okay, and I've highlighted a section. It says, the Essure procedure should only be performed by knowledgeable hysteroscopics who have completed the Essure training program, including preceptoring and placement until competency is established, typically 5 cases. Yes. Okay, most doctors that did this type of insertion had very little experience at hysteroscopic doctors. That means using the hysteroscope to place the device. They were even in the expert hands. The placement of Essure was being improperly done in approximately 14% of patients, even in expert hands. On top of that, the migration of the Essure device occurs in between 3 and 4% of patients. So a significant number of patients were having these devices placed incorrectly, or they were migrating after they were being placed. And so when you hear an expert hysteroscopic doctor, very few of us, even the board-certified OBGYNs, very few of the board-certified OBGYNs know what they're doing as far as placing Essure device, and that's why women were getting hurt. Okay, that's what was happening. So, nevertheless, apparently after 5 cases, you were supposed to be an expert on how to place this, but in comparison to those that were actually doing the studies, they were placing hundreds, if not thousands of them, were still making mistakes up to 14% of the time. You can just imagine how many women were hurt by that. So that's my first highlighted section. But the reason that I wanted to do this today is because a lot of patients were saying that now that the Essure device is in place and I want to get this device taken out of me, my doctor is not even recommending that there be any preoperative studies done. They're saying, oh, we'll just go in there and we can take it out. Now, let me give you a little bit of history related to that. It is not uncommon, or it was relatively common, for doctors with very little experience to be placing these devices, and the trainers, who were not even doctors, were telling the doctors that it was okay to place more than one device per fallopian tube. And if you look online, you're going to see some doctors placed 2 or 3 Essure coils in just one fallopian tube. And many times these Essure coils would not take, and then they would migrate into the pelvis, causing significant problems. So when you're going to a doctor who is going to remove these devices, number 1, 14% of the time the devices were improperly placed. Number 2, 3 to 4% of patients had migration of the coils. And if any doctor tells you that they do not migrate, they're wrong. Go find another doctor. Get a second opinion. Get another opinion. Because they're going to be the ones that are going to end up hurting you. Okay? So 14% of the time these devices were improperly placed. 3 to 4% of the time these devices migrated. Okay? That's just the start. Next, depending on where the coils are located, you have to decide how you're going to remove them. Okay, there is a grading system associated with the Essure devices. Grade 1, grade 2, grade 3 position. If the coil is in grade 1, the majority of the coil is inside of your uterus. If it's in grade 2, about half of the coil is in the uterus, half of the coil is in your fallopian tube, or up to 3 centimeters outside of your uterus. That's grade 2. And grade 3 means that the entire coil is more than 3 centimeters outside of your uterus and into the fallopian tube. All right, so let's be realistic about this. If you have a coil that's in grade 1 position, or more than half of the coil is in your uterus, How in God's name are you supposed to remove the coil by just removing your tube or opening up the tube and trying to pull out this coil through your tube, out through that's coming out of your uterus? Okay, there is plenty of YouTube videos where those doctors are making major mistakes by pulling on these coils. And I even saw one video that says there's not a big deal because as long as you put a camera in and you're looking at it hysteroscopically, that you're gonna have an okay removal of the coil, because you can see what you're doing from in the uterus as well as from laparoscopic approach. That's wrong. That's wrong. Why? Because the coil has an anchor device on the end of it that's inside of your uterus. So when you start pulling on this coil, you significantly increase the risk of snapping the coil, okay? And now you leave a segment behind. The anchor can embed itself or anchor itself just like a hook into the fallopian tube, which you can't even see hysteroscopically. So there is literally videos on YouTube that says, look how easy it is to remove this device. And you don't have to worry about it because as long as you're looking at it from a hysteroscopic point of view, that you can pull on it. You can't pull on it. Do not pull on it. Do not allow your doctor to pull on it. Go to someone else who's telling you that it's okay to pull on it. Okay, that's basically what I wanted to address on that particular point. Now, the last page, again, because there's 15 pages in this handout. Why do you need to get preoperative scans? Number one, grading. You have to determine the grade of the coil, what position it's in, before you attempt to remove it. And if 14% of the time it wasn't properly placed, the doctor should never assume that it's in the proper place, especially if they're trying to remove it only by removing it through a laparoscopic and opening up the fallopian tube as a salpingotomy and removing it and of course pulling on it, okay? That's number one. Number two, if it's in grade 1, you shouldn't even be attempting to remove it laparoscopically. Now, I mean, you can try for corneal resection, but probably the best approach is going to be a hysterectomy, bilateral salpingectomy, removal of the uterus and the fallopian tubes to avoid pulling on it. So, why do you do the preoperative studies? Again, to try to figure out exactly where the coil is, how far into the uterus it is, and how many there are. Remember, a lot of doctors were placing these devices and putting more than one coil in each fallopian tube. And sometimes these coils would come out of the fallopian tube and migrate around in the intestines, okay, all the way up to the diaphragm, all right? So if your doctor did not bother to get a preoperative scan, and they're thinking that there's two coils, or, oh, this is going to be an easy removal, they're setting themselves up for failure, setting themselves up for hurting you, setting themselves up for having to do multiple surgeries on you. And of course, you don't know, you're expecting the doctor to be the expert, and many times they're not the expert. Many times they're not the expert. And even in those that claim to be experts, they keep screwing up. They keep making the same mistake over and over again. Now, that's why you do the preoperative studies. And what are the preoperative studies? My recommendation is to do not just an X-ray, because I know a lot of patients have one X-ray. And they say, well, this is the X-ray. Now, those coils are located in 3 dimensions, front and back and side to side. So one X-ray of a front and back is not enough to determine exactly the exact position of a coil. I recommend, if you're going to do only X-ray, that you do an X-ray in the anterior posterior, that means front to back, and a lateral view from the side, so that you get an idea, is it how far to the front is it, how far to the back of it is it. Now, not only of the pelvis, but of the entire abdomen, all the way up to the diaphragm. Okay, because you're looking for a migrated coil, or you're looking for a coil that was placed by a doctor who didn't know any better and put more than one coil in each fallopian tube. All right? So that's if you're using only X-ray. I prefer to use a CT scan, which I believe is more sensitive, especially if you're looking at how far into the fallopian tube they are. Okay? And of course, you can do an MRI as long as the TELSA field strength is approximately 1.5 on TELSA strength. Now, Suppose that you've done the preoperative scans. Ask your doctor, what's the grade? Is it grade 1? Is it grade 2? Is it grade 3, doctor? If your doctor does not know what the grade is or can't explain to you what the grade is, go to another doctor. Simple as that. Because if your doctor doesn't know what a grade is, they failed. They failed the test, okay? Go to another doctor who's going to give you the correct information. Next, as I said before, there are many different ways to remove these. You shouldn't be pulling on them. If you're going to be, this is what confuses me, but I wanted to state one particular thing. If this is not just my opinion, again, I want you to go to page 14 on the PDF file. Subsequent to placement procedures, location of the Essure inserts should be confirmed through imaging prior to any attempted surgical removal, as the appropriate surgical approach will be influenced by the location, availability of intraoperative fluoroscopy and/or intraoperative X-ray is recommended to identify the location of the inserts or fragments of the inserts during the removal procedure. Number one, you need preoperative studies to determine how many coils and where they're located. Number two, you need to know where those coils are, because if they're located in a place that's more difficult to remove, you're going to need a general surgeon, you're going to need additional surgeons in the OR to help you remove them properly. More importantly, you're probably going to, if you're going to only remove the fallopian tube and leave the uterus behind, you're going to need intraoperative fluoroscopy. That means a specialist to help you determine where they are and if you're leaving any fragments behind. For all of those patients that had the uterus left behind, did they do an intraoperative fluoroscopy? Did they do a post-operative X-ray or CT scan on you? And of those women that say, no they didn't, and I didn't find out till a year later that a fragment was still there, now you know where your doctor made their major mistake, and that's why you still have a problem, why you still are being harmed, and why the doctor failed you and failed going below the standard of care with a potential malpractice lawsuit, okay? That doesn't help you and when you were harmed, but at least you know that this is exactly where it is in the manual. Why would a doctor not follow the manual instructions? Because they think that they're bigger than that their arrogancy is getting the better of them. Their egos are getting the better of them, okay? Let's come back down to earth. We're all human, okay? Read the manual before you start doing a procedure, okay? That's the minimum that I'm talking about. Now, this does not necessarily apply, but it's still important. Okay, it's still important. There are still doctors that are doing a hysterectomy and bilateral salpingectomy, but still cutting the coils, still cutting the fallopian tube and cutting through and taking out the uterus first and then taking out the fallopian tubes. There are doctors that are doing these approaches vaginally without having any idea what they're looking at, which that's what the laparoscope should be doing, okay? Specifically, page 14. For all surgical removal procedures, care should be taken to avoid transecting the insert during removal. The laparoscopic devices, scissors, are not designed to cut through metal, okay? They're not. Yet the doctors are doing that. They're using these devices to cut through metal just like they used to with morcellation, okay? Page 14 is right there. If your doctor cut the fallopian tubes near the coils intentionally to separate them, they were wrong. They shouldn't have done that. Why? Because if you've ever seen or tried to cut an Essure coil, it fragments into tiny microscopic pieces. All right, now these end up in your pelvis and you end up with symptoms or no resolution of symptoms, and yet you can't have a test to scan it to figure out what happened because the sensitivity of a CT scan, ultrasound, or MRI is not sensitive enough to pick up the microscopic fragments that were left behind, yet your body is sensitive enough to react to it. That's what I'm talking about. So if there's any take-home message today, please, Everyone that's ever had an Essure removed, go get this manual off of the Essure.com website immediately. Read it, go through it, figure out if it was done the right way. Number two, for those that are going to get the Essure device taken out, especially if they're only going to be taking out the fallopian tubes and leaving the uterus behind, read this manual before and quiz your doctor, because if your doctor can't answer your questions, you need to find a doctor that can answer those questions and follow the manual as instructed. Because once you have the surgery done and there's a mistake made, it may not be possible to fix that mistake. I hope this has helped you. I hope that this has been informative. I will continue to do these little mini presentations, and I'm going to make a copy of this. Again, please follow us on drnovoa.com on the Facebook page. That is also my web page, but for Facebook forum on all of these little mini lectures, we're going to be putting them on Facebook forum as well as YouTube under Dr. Novoa. But please follow us on drnovoa.com on the Facebook page, because I'm going to be adding more and more informative information related to foreign body reactions, post-tubal ligation. And for those ladies for post-tubal ligation, this is just as important for you, because if you're trying to remove the Essure coil and you're trying to reverse a tubal ligation, it's very, very difficult. There's only a few doctors in the whole world that are expert at them, and one of the best is going to be Dr. Charles Monteith in Chapel Hill, North Carolina. So for the PTLS group, yes, Dr. Charles Monteith is the expert related to post-tubal ligation syndrome and Essure reversal. I hope this has been informative. Again, please follow us on drnovoa.com and also on our website, and follow us on YouTube. I will be posting these videos on YouTube this week. Thank you so much. Have a nice day.